So cognitive behavioral therapy can be a really effective way to help people diffuse some of that anticipatory anxiety, some of that anxiety where you're thinking, oh my gosh, I didn't sleep well the last 2 nights, I'm not going to be able to sleep well now, I just know I'm not going to be able to fall asleep, and that anxiety then becomes another trigger for the insomnia. So cognitive behavioral therapy can really help with relaxation, with uncoupling some of those automatic assumptions or thoughts that you have about, oh gosh, I'm not going to be able to fall asleep, and just sort of helping people understand that, hey, even if I have a bad night's sleep here and there, that's not going to just wreck my level of functioning the next day. The difficulty sometimes is finding people that are knowledgeable or skilled in doing cognitive behavioral therapy specifically for sleep. But there are other forms of therapy. There's other forms of cognitive therapies for sleep. There's relaxation training. People sometimes do things like, visual imagery, biofeedback. Relaxation therapy, muscle relaxation probably doesn't work as well, at least according to the studies, as cognitive behavioral therapy or as medicines do. But there's a lot of different tools out there that people can avail themselves of. And especially with younger people, we're more likely to explore those to a greater extent since we're, in general, less likely to use medicines in people under the age of 18.
Chris, I might just to go a little bit further on that cognitive behavioral therapy piece and what that really is. The cognition is the thought.
Right.
So like you mentioned, we have these automatic thoughts that, oh man, I'm not going to be able to function. If I miss this night's sleep, I'm not going to be able to function. And the other thing is a common thing that we do, and I always do, is I wake up, look at the clock, and then I say, oh, it's been 15 minutes, I haven't gotten to sleep. Well, it's been a half an hour. Geez, now it's been an hour. I'm never going to get to sleep. So you cause this huge adrenaline release. It's an anxiety response, and you're not going to sleep when that happens. So, so the behavioral part of that then is of the therapy that they do is that the therapist will help the patient there, help the person come up with things to do. Like, what would you do? Well, first thing is kind of obvious: turn the clock, so you don't know how long it's been, so you don't sit there and panic about that part of it. The next thing is, if it feels like it's been 10 or 15 minutes and you haven't gotten back to sleep, get out of bed,
right,
so that you don't start associating your bed with anxiety. Get out of bed, go into the living room, and read a boring psych textbook. Is what I always tell my patients. I'll loan you a psych textbook. But that's nice and boring, something to put you right to sleep. But anyway, something boring. Don't go in and watch Terminator 2 or watch some big action flick or play video games and blow up a bunch of aliens. Nothing that stimulates you. You want to go in and do something comforting and relaxing. When you start to get sleepy, you go back and you lay in bed until you fall asleep. Again, you do the same thing again. If it gets to be 15 minutes or so, then you get back up. But you stay on your sleep cycle.
Yeah.
Like you mentioned earlier, you stay on your sleep cycle and you get up still. Even if you only got 3 hours of sleep that night, you get up at 6 a.m. or whatever time you've chosen. You don't nap the next day, and by the time 10 o'clock or whatever time you've chosen hits the next night, you're going to be exhausted. We call that sleep pressure. So that's the cognitive, the thought piece and the behavior piece. You change those things to try to help you get to sleep, and it's extremely effective.
Exactly, and it's something that we don't think about enough because it sounds like, well, it's so common sense. How could that possibly be helpful?
Yeah.
But it really is. And again, the other thing that's important to point out is that you can't pay back a sleep debt. You can't catch up on missed sleep. So it doesn't make sense, and you're actually probably hurting yourself if you get into that pattern of, I didn't sleep last night well, so I'm going to take a nap today. No, just struggle on through that and stick to your normal sleep-wake cycle. That's the most reliable way to wind up back in a good sleep-wake cycle. In fact, there's even places that are doing, sort of taking that sleep pressure thing one step further, and they're doing sleep deprivation as a way of treating insomnia, where they'll bring people in and keep them awake for 36 hours or 48 hours. And sometimes it really can have a nice effect on helping to sort of reset that circadian rhythm. You almost always have to take somebody someplace to do that, because just telling people to do it themselves at home almost never works. But
in the older adult population, that's classic, because they don't have to get up and go to work.
Right.
And they, I don't sleep at all during the day, but the family says, I go in and Grandma's sitting in the chair with her eyes closed. Maybe she's not sleeping, but she's resting her eyes. Well, what do you call it?
Yeah,
that's probably
resting my eyes.
And then her body gets to sleep out during the day, and then it comes nighttime when she wants to go to sleep, she can't get to sleep. So
exactly.
That's a extremely common thing. The behavioral piece, I think, is we underestimate a lot.
Yeah, and we get so much anxiety and worry about, oh my gosh, I'm not going to be able to fall asleep. It's a double-edged sword. Then it just comes around and sort of bites you the next night.
Right.
Other questions that folks have, or comments? Or?
You know why in menopause women seem to have insomnia?
Great. The question was, why is it in menopause the women seem to have more trouble with sleep? A variety of reasons. Number one, just some of what we call the vasomotor changes, the hot flashes, the night sweats, pretty disruptive to sleep. Also, estrogen and progesterone have effects on sleep architecture and have effects on sleep. So as you approach menopause and as your ovaries decrease the amount of estrogen that they're producing, as you see falling hormonal levels, that can cause problems with sleep. Even if you look at a woman across her menstrual cycle, you'll generally see higher levels of estrogen, which is sort of the first half of your menstrual cycle, being associated with better night's sleep, and then higher levels of progesterone and lower levels of estrogen being associated with less good sleep, less restful, less restorative sleep. Actually, these hormones also impact your risk for sleep apnea. Women are somewhat protected from sleep apnea compared to men during their reproductive years, partly because there's some evidence that these hormones are almost like respiratory stimulants in a way. It almost can stimulate your drive to breathe. Also, estrogen in particular, and maybe some of the other reproductive hormones, seem to have an effect on strengthening the muscles in the back of your throat to help keep it open. So you're less likely to have your throat closed in the middle of the night and have sleep apnea and obstruct your airway if you have good levels of estrogen. Interestingly, after menopause, women's levels of sleep apnea really go up pretty dramatically, and they're just at much risk as men are after that. So there are a number of things going on around menopause that can contribute to our vulnerability to sleep-related or to breathing-related sleep disorders, and also just may play a role in insomnia. I just had a patient in my office that I had seen again last week, and she was convinced that this antibiotic medicine that she had been prescribed had wrecked her sleep. And what we really noticed was that as we had her chart her sleep out, this was really having an association with her menstrual cycle. She was taking this antibiotic once a month, and it sort of happened to be around the time that she was ovulating. So we noticed this tie-in between the times of her period when she probably had more estrogen in her system, she was sleeping better, and then later in her cycle, her sleep just fell apart. So there's a lot of reasons, and we're just sort of beginning to understand this, but there are some hormonal effects on our ability to sleep and our ability to sleep well.
You know, you see a lot of commercials for sleep, okay, and one of them that we see a lot of, and I'm sure everybody here sees a lot of, is restless leg syndrome. Can you mention that for a minute, explain what that is? Yeah,
restless leg syndrome is what's called a movement disorder. Restless leg syndrome is the sensation of, people talk about it in different ways. I had one patient describe it as, my legs were having panic attacks. Other people talk about creepy crawlies. And it's not pain, and it's not your legs jerking. You know how sometimes your legs jerk right as you're on the cusp of falling asleep? That's something different. Restless legs, your legs may not move at all on their own, but you have this sensation where it's just intensely uncomfortable. It's typically not painful, but it's just this feeling. It's like, gosh, I almost got ants crawling on them or something, or they're just I gotta move them, and the only way I get relief is by moving them or getting up and getting around. People are vulnerable to this in different stages of their life. You can see it in childhood sometimes, actually significantly associated with what we call growing pains. A lot of kids, when they're going through growth spurts, will have this happen. Women are more vulnerable to this than men are, partly because one of the things that puts you at risk for restless leg syndrome has to do with your overall iron stores in your body. And so since women are losing blood monthly with their menstrual cycle, they have some relative anemia in general compared to men, and they may be at greater risk for having restless legs. There are a number of medicines that can increase your risk for restless leg syndrome. Actually, antihistamines like Benadryl can make it worse. Antidepressants that work on serotonin can make it worse. And this, it affects people to varying degrees. I've seen some people that have it so bad that, it's just terribly debilitating. These people cannot sleep throughout the night. Their sleep is just horrible because they're up all the time, walking around, rubbing their legs, taking hot baths or hot showers to try to get comfortable.